Thank you. Thank you very much. Thank you for the invitation. Now I will try to share my slide. Okay. And I thank you also, Janssen, that sponsored this symposium, this lecture. So this I'm at disclosure. And so let's start to see what happened to new patient with ulcerative colitis today, actually. As you can see here from this collection from Europe, as soon as after 5 years, a substantial proportion of patients tended to extend the inflammation through the rectum to the left colon up to all the colon. So this means, in my opinion, that we are still not able to manage in an optimal way patient with ulcerative colitis, and it's quite well known that the so-called disease extender, as demonstrated from this Danish data, and here are 40% around of patients with new diagnosis. You see that after 5 years extend their inflammation are, as you can see here, at high risk of colectomy. So still, probably we have to know a lot. We have understood that. We are listening in the previous lecture how is going further ahead the research in prediction and also in molecular predictors. But today we have to manage in this way our patient with ulcerative colitis, just to step the potential of therapy according to the severity of disease at presentation or at follow-up. And we have in this category of severity, that are so-called moderate to severe disease, that we have a lot of choices today, and every choice is performed as the aim to try to attain in the majority of our patient a rapid remission of symptoms, to maintain as long as possible a state of steroid-free clinical endoscopic remission, but also with the final aim to improve patient quality of life in every patient in front of us in the outpatient clinic. And still, we have new endpoints that are on the horizon. This is the very recent consensus on the treat to target, and as you can see here, we should prompt our therapies, try to achieve as first target the symptomatic response, but then try to achieve the best according to current knowledge that we can achieve in patient with ulcerative colitis in this case. So normalization of systemic and intestinal inflammation, and finally, as a final target, endoscopic healing and improved quality of life without any kind of disability. Probably we will in the near future also strive and try to reach histological healing in our patient with UC, and we will see why. So as I told you before, we have available in the category of patient with moderate to severe ulcerative colitis today, when conventional treatment is failing, 4 different categories of drug: the classical anti-TNF, the anti-alpha-4 beta-7 integrin, the anti-JAK, the only anti-JAK, and very recently also the possibility to use the anti-P40 subunit of the interleukin 12-23, that is ustekinumab, and we will focus on that drug today. So why ustekinumab could have a rationale? Because, I mean, just blocking the P40 subunit of the IL-12-23 is a sort of reducing the possibility to T-cell differentiation in patients with IBD, and in particular with Crohn's and ulcerative colitis. You see in the cartoon how important are these 2 kinds of cytokines in acting on the naive T-cell and helping the naive T cell to differentiate in Th1, Th17 subset, and then you see that the release of cytokines that amplify the inflammation. So the rationale, very simple, is that one. So targeting T cell differentiation in ulcerative colitis. And probably you see and you remember, this is the Unified program, and I will have an overview on the program with the last release. This was run a few years ago, and many patients, around 1,000 patients, were randomized to receive as an induction IV ustekinumab 6 mg/kg body weight, or 130, or equivalent placebo, and patients who were responding at week 8 to the IV ustekinumab administration were re-randomized to enter in the maintenance study. That was 90 mg one arm every 8 weeks, 90 mg sub-Q the other arm every 12 weeks, or equivalent placebo, with the end of the maintenance period at week 44 of the maintenance part, and the possibility of the patient to roll over the long-term extension program, and the possibility also to jump and to adjust the dose at any time. And later we will see the result at 3 years. Well, the primary endpoints are classical endpoints of phase 3 trial, and I will focus just only on the primary one. That was clinical remission, both symptoms and endoscopy after induction, and clinical remission at the end of the maintenance period, and the list of major secondary endpoints. So let's go to primary endpoints. Both the arm containing ustekinumab IV achieved clinical remission in a significant proportion, in a significantly higher proportion with respect to patients who received equivalent placebo at week 8. And same was for major secondary endpoint, endoscopic healing and clinical response. You see how significantly higher with respect to placebo were both endoscopic and symptomatic result. But something of new was, according to the FDA requirement, was achieved in patient enrolled in the ustekinumab program. The concept of histoendoscopic healing, so having both endoscopic healing and histological healing in the same patient, according to endoscopic subscore of 0 or 1, and histological healing according to this definition. Less than 5% of neutrophils in the epithelium without creep destruction, no erosion, ulceration, or granulation. And as you can see, a significantly higher proportion of ustekinumab treated patients after 8 weeks achieved this very important endpoint with respect to equivalent placebo patient. And what about maintenance? A significantly higher proportion of patients maintained on ustekinumab every 8 weeks or every 12 weeks achieved clinical remission with respect to patients that received ustekinumab in induction but then were maintained with placebo. And similarly, these percentages were significant, also stratifying patients in the subgroup of biologic failure and no biologic failure. So apparently ustekinumab is working clearly better in bio-naive patient, but also is working good in bio-failure patient. And what about the histoendoscopic mucosal healing, histological endoscopic improvement? All these endpoints at the end of the maintenance period were significantly higher in the arms treated with ustekinumab every 8 or every 12 weeks with respect to placebo maintained patient you see here. And very interesting, it was reported that patient who had an histological improvement after induction then achieved in a significantly higher proportion of patients all these positive outcomes at the end of the maintenance period. So more patient in endoscopic improvement, clearly more patient with histoendoscopic mucosal healing, more patient in clinical remission and steroid free clinical remission. So this is a sort of piece of interesting evidence that probably achieving histological remission could be an added and favorable endpoint that maybe in the future we will pursue in our patient with ulcerative colitis. What about systemic and intestinal inflammation during the maintenance period? As you can see here in these kind of curves, people and patients who were treated and maintained with ustekinumab maintained a low level of CRP and fecal calprotectin with respect to patients who were maintained on placebo. And similarly, this is a very important point that we are quite frequently not speaking enough, but at the end of the maintenance period, a significantly higher proportion of patients maintained on ustekinumab achieved improvement in the quality of life. You are seeing here all the main bowel, emotional, systemic, and social, and this is very important by the patient point of view, in my opinion. What about immunogenicity? Very low level of anti-drug antibody in patients treated with ustekinumab, as you can see on the left. And this is very important. The serum concentration were not affected according to receive or not receiving an associated immunomodulators. So probably ustekinumab works at the same in monotherapy and in combination therapy. No particular new safety findings at the end of the maintenance period. We know quite well from Crohn's disease the safety profile of ustekinumab, and as you can see here, there were no particular signal in a patient with ulcerative colitis. And finally, after the maintenance result, a very recent meta-analysis has been published, and as you can see here, comparing all the drug that we have available in this segment of patient, here in bio-naive patient, you can see that according to the randomized trial result, how ustekinumab is quite the best performed with respect to the other drug used in these patients that are moderate to severe failing conventional therapy, both in terms of clinical response and clinical remission. But as I was saying before, very recently data on 3 years of ustekinumab has been released, so 2 years of maintenance and long-term extension. You can see here how quite high were, this was the ITT analysis of IV induction responders randomized in maintenance study. And as you can see here, with regard to symptomatic remission through weeks 152, a substantial higher proportion of patients better in bio-naive than in bio-failure maintained remission along the follow-up. Very important, high proportion of patients that were receiving steroid at baseline were able to withdraw steroid, as you can see here in these two figures. The upper one, the corticosteroid-free patient, and the lower one, the reduction of the daily prednisone equivalent corticosteroid dose. And here you can see how many patients were in sustained corticosteroid-free symptomatic remission through weeks 152. So if you respond to ustekinumab IV, you have high probability to maintain a response and to stay without any kind of steroid. Again, through week 156, no particular difference with regard to side effects. We know the profile quite well, and as you can see here, there were no difference in the class and with respect to placebo-treated patient. So I would like to finish with a very short clinical scenario. This is one patient, male, 35 years. He was diagnosed 1.5 years ago with extensive UC, moderate severe activity at diagnosis, Mayo Endo 2, and he required 2-month course of oral steroid, topical 5-SA. He went to clinical remission, and he was maintained on 3.2 grams of oral 5-SA along the follow-up. But after 5 months, he got a flare again. with inflammatory markers, again steroid plus thiopurine, but he was not able to tolerate, and he was unable to wean off prednisone. So up to 15 milligram a day, he was fine, but just trying to decrease the dose, then he was relapsing. So classical steroid dependent UC. And what next? These are patients that in my outpatient clinic are quite worried to me, because they have the risk, the serious risk to develop, as you can see here, chronically active ulcerative colitis. And these are probably the worst patients to manage, because they have the risk to develop a disabling disease. They have the risk to have a severe flare, and also to develop complication in the long-term colorectal cancer. They have a high risk of surgery, and these all reflect on the quality of life of the patient. So today, for this category of patient, we have different possibility, actually. We can start anti-TNF, in this case as a monotherapy, because he was not tolerating thiopurines, or maybe anti-TNF and methotrexate. We can start Vedo, we can start Tofa, but also we know now that we can start in this patient also Stequinumab, because as far as the result of the phase 3 program is concerned, and also the long-term extension new results are concerned, we know that ustekinumab could be a good opportunity. So in conclusion, dear colleagues, I would say that still we need to know a lot in ulcerative colitis, because there are a lot of unknowns. The current therapeutic strategy have many unmet needs, and we are trying to improve day by day. The therapeutic target are changing from symptom control to more objective measure of disease control. We are using also in our practice composite endpoint at some time in the follow-up of our patient. The concept of complete remission, including not only symptoms, but also endoscopy and histology, is an emerging target. Still, we are not using histology in the real life, but probably in the near future, we could try to, we could have also histology as an endpoint. And we have seen that the evolving treatment landscape in colitis looks promising, because we have different possibility, but we know today that in patients with moderate to severe ulcerative colitis, ustekinumab show efficacy in induction and maintenance of clinical remission, endoscopic remission, histoendoscopic mucosal healing, and long-term steroid-free symptomatic remission, with an adverse event profile that is quite favorable, because we know since some years that the side effect profile of ustekinumab is quite good. And I thank you very much to have listened to me.